Hello, and welcome to this Clinical Care Options Oncology podcast. I'm your host, Mandy Murph. Today's episode features a discussion between the hematologist, Dr. Carlos Castro from Duke University, and Dr. David Dingli from the Mayo Clinic. These experts will discuss the current landscape of approved therapies for use in paroxysmal nocturnal hemoglobinuria, including various inhibitors of the complement cascade targeting complement component 5, complement component 3, factor B, and factor D, along with strategies to incorporate these agents into treatment for this rare disease. They'll also discuss emerging agents and strategies that may further enhance the care of patients with PNH in the future. This episode is part of a larger educational program titled Clinical Focus in Paroxysmal Nocturnal Hemoglobinuria, New Strategies for Evading the Complement Cascade. For more information on the speakers and a link to the larger educational program, please visit the show notes for this episode. And now, let's get started and hear what these experts have to say about this important topic.
All right. Welcome, everybody. This is a podcast about paroxysmal nocturnal hemoglobinuria, or PNH. I am joined by my colleague, Dr. David Dingli from the Mayo Clinic. I'm Carlos Castro at Duke University. We'll be talking about PNH, which is this rare and very unusual disease that affects the blood. Patients with PNH can present in a lot of different ways, but the classic way is by having hemolysis of their red cells intravascularly and presenting with dark urine and a lot of symptoms, including abdominal pain, fatigue, etc. PNH has gotten much more exciting over the past 10 to 20 years with the development of complement inhibition, which has really revolutionized our treatment for this disease. And there's even more agents being developed that we're going to be talking about. So I'm going to turn it over to Dr. Dingli to talk about PNH and its background and pathogenesis.
Thank you, Dr. De Castro, and thank you all for joining us today. So as Dr. De Castro mentioned, the disease is rare, a few patients per million, but the prevalence is increasing because patients now are living much longer with this disease. In fact, I think this is a very important point, that now the patient with PNH who is properly treated can expect a normal life expectancy. There are many features that have to occur for this disease to manifest. There is a mutation in a gene called PEGcetacoplan, which is fundamental for the synthesis of the GPI anchor, which is required for a number of complement regulatory proteins to be expressed on the surface of cells. However, this is not enough for PNH to manifest itself. The clone, this mutation that arises in a hematopoietic stem cell, must expand. And there are various mechanisms of how this happens, some of which are understood better than others. But again, this is not enough to explain the disease. The reason red cells are destroyed is because, whereas white cells and platelets have other mechanisms to protect them from complement activation, red cells do not. Specifically, they do not express CD46 and complement receptor 1, which also regulate complement activation. In our body, complement is continuously active at a very low level through the alternative complement pathway. So there is continuous hydrolysis of C3, which is amplified through the interaction of C3 with factor B and factor D. Finally, we need to remember that complement factor 3 is attached on the surface of cells. And it is this combination of features that results in the disease. As Dr. De Castro mentioned, the fundamental feature is intravascular hemolysis, typically in the patient who is not on therapy. And this can manifest itself as anemia with symptoms such as shortness of breath, fatigue. The patient can have hemoglobinuria, so they may have dark urine, classically in the morning, but this is not essential for the diagnosis. And because there is free hemoglobin in the blood, we deplete nitric oxide, and this results in smooth muscle spasm. So patient can have abdominal pain, muscle cramps, esophageal spasm. And the combination of these features also increases the risk of thrombosis, which traditionally was the main reason for death in patients with untreated PNH. And thrombosis can be in usual sites or unusual sites, in particular the splanchnic circulation, so the portal vein, the superior mesenteric vein, etc. But patients can also have arterial thrombosis.
Thanks, David. About 20 years ago, we entered a new era of having a complement inhibitor. It was developed by some investigators at Yale who wanted to inhibit the complement system to try to block myocardial damage during a heart attack or a myocardial infarction. And they chose C5 as the target, the C5 component of complement, in part because children who are deficient in C5 get a meningococcal infection. They don't get other types of infection. So they developed a monoclonal antibody against C5, and they started clinical trials from this. And Pete Hillman in England heard about this and said, this would be a wonderful new treatment for PNH. Do you mind if I try this? And eventually he was able to convince them to try it in a small pilot study of 11 patients. And it was pretty impressive that blocking complement at C5 stopped hemolysis within a week or two, and patients felt much, much better. And that was the drug we now call eculizumab. It was given as a loading dose weekly for 4 weeks, and then every 2 weeks. It was very well tolerated. All patients had to be vaccinated against the meningococcus before getting the drug, and they had to be educated to be aware of the risks of meningitis and the symptoms so they could get immediate treatment. Eculizumab blocked hemolysis in marked ways, and later we learned that it also seemed to markedly decrease the rates of thrombosis in these patients, which was the major cause of death in many of these patients. So not only were patients feeling better, but they were actually living longer with complement inhibition. Later, ravulizumab came out. Ravulizumab is a modification of the same monoclonal antibody. It allows it to stay in the circulation longer, so you can achieve higher levels for longer periods of time. It's given as 2 loading doses 2 weeks apart, and then you go on ravulizumab every 8 weeks. So it was a much more convenient drug in addition to having somewhat higher levels. Now, the studies that were done with it were non-inferior studies, so we really can't claim one is better than the other. But most patients in this country were switched to ravulizumab just because it was so much more convenient. Ravulizumab also seems to lower the rate of thrombotic episodes. And really, these 2 drugs became the standard of care in the country for many, many, many years. Now, there are some problems with C5 inhibitions that we learned about. The biggest one is probably the development of extravascular hemolysis. So with these 2 drugs, it's pretty uncommon for hemoglobin levels to go in normal range, and LDH levels stayed just above normal, but not normal. And as time went on, we learned that all these cells, because we're blocking C5, all the red cells PNH red cells are getting coated with C3. They have no way to remove C3 fragments from their surface. And in some patients, this was leading to uptake in the spleen and the liver and leading to extravascular hemolysis. And in some patients, it was pretty significant. They had really suboptimal responses to C5 inhibition. And so this led us to a new age of trying other parts of the complement system for inhibition.
Some patients with PNH would continue to require transfusions. And as Dr. Castro mentioned, many patients do not normalize their hemoglobin, even though their fatigue improves. And the phenomenon of extravascular hemolysis was actually identified fairly soon after the availability of eculizumab, where patients were found to be Coombs positive, whereas classically the untreated patients with PNH will have a Coombs negative hemolytic anemia. So the first drug that was developed to address this problem was pegcetacoplan. It is a cyclic peptide that blocks C3, and therefore C3 does not accumulate on the surface of red blood cells. And the idea here is that it will prevent both intravascular hemolysis as well as extravascular hemolysis by preventing coating of red cells with C3 that opsonizes red cells for the reticuloendothelial system. Pegcetacoplan was studied in 2 clinical trials. One was called PRINCE, one was called Pegasus. And one of these was in the treatment-naive population. The other study was in patients who were already on a C5 inhibitor. At that time, most of these patients were on eculizumab. Pegasus took patients who had patients with persistent anemia, and they were randomized to either pegcetacoplan or continuing on the same therapeutic approach. All patients initially received pegcetacoplan in combination with eculizumab, and the hemoglobin improved in these patients by 2 grams or more. And then, based on the randomization, patients could continue on pegcetacoplan alone or switch to their C5 inhibitor. And as expected, the patients who switched back to the C5 inhibitor, the hemoglobin dropped to their baseline. And this study clearly showed that proximal inhibition can improve hemoglobin in many patients, lead to transfusion avoidance. And again, the quality of life improves based on several scoring systems. Pegcetacoplan needs to be given at least twice a week at home. It's a self-administered dose. We're using a pump, but it's a bit inconvenient for some patients, although patients have benefited from this approach. Soon after, iptacopan started being studied. This was, again, a major step forward because it is an oral agent that inhibits factor B. And factor B is a crucial component in the amplification loop for the generation of C3 through the alternative pathway. So the idea here is that by going even more proximal, preventing the amplification loop from generating C3 activation, we can prevent both intravascular and extravascular hemolysis. And iptacopan was studied also in 2 trials, the APPLY and POINT, and subsequently it was studied in the PULSE clinical trial. The data suggests that both in patients who have been previously on a C5 inhibitor or even treatment naive have an improvement in hemoglobin because hemolysis is very well controlled. The LDH essentially returns to normal. The reticulocyte count returns to normal. And the vast majority of patients who are on iptacopan would expect hemoglobin above 12. Quite a few will have a normal hemoglobin, and transfusion avoidance is extremely high. The quality of life metrics showed significant improvement, with a FACP score, for example, being similar to that of the general population when matched for age.
Patients who start treatment, if they don't respond well, the etiology for that response has to be looked at. But if it turns out it's either extravascular hemolysis or a different problem if you're on a C5 inhibitor, then there's no reason you can't switch to oral iptacopan or one of the proximal inhibitors. Similarly, if you're on a proximal inhibitor and you're having problems with either recurrent breakthrough hemolysis or other issues, we can switch to a different proximal inhibitor, such as oral iptacopan or one of the other ones, without too much problem, and see if they can tolerate that better and have less side effects or less problems with breakthrough hemolysis. One of the AEs that we learned about with iptacopan was a rise in lipids that occurred in about 6% of patients. Some required a statin or a treatment, but the most they were able just to watch and use diet measures.
Sometimes with iptacopan, patients complain a bit of a headache, but I do not think that it's something specific for this drug. If one looks at the literature, I mean, headache seems to be a very common symptom in PNH. And even in the original eculizumab trials, patients would have reported some headaches, and generally these get better with time.
With iptacopan, there's nothing predictive that they're going to get a side effect, and there doesn't seem to be a steady time course. I will say the headaches usually occur early with the treatment. We do recommend, patients are monitored with initiation of the treatment, every month or so to make sure they're doing okay on it. But after that, they can be seen every 3 months or every 6 months. And, we talk to them about their symptoms. We talk to them about how they're feeling, and then we go into their labs and see if there's anything going on there. And if there's something, then it needs to be investigated. But usually most patients have not had any problems with that, remarkably enough. So it becomes a very easy visit once you see they're doing well and don't have any complaints and their labs look good.
The additional drug that has been studied was danicopan. Danicopan is also an oral agent. It has to be taken 3 times a day, and it is only approved in patients who are already on a C5 inhibitor with a suboptimal improvement in hemoglobin. The idea here is that the danicopan, which will inhibit factor D, will prevent C3 activation and accumulation on the surface of red cells, while also the presence of the complement 5 inhibitor would prevent intravascular hemolysis. This was studied in the alpha trial, and again, many patients had improvement in hemoglobin by over 2 grams, many patients normalizing their hemoglobin, and the high incidence of transfusion avoidance. The other good piece of news with all these proximal inhibitors that the risk of infections does not appear to be increased compared to C5 inhibitor therapy alone. We can move to the C5 inhibitor crovalimab.
Crovalimab was developed using something called SMART technology, so it lasts in the circulation longer. Therefore, it can be given in smaller doses subcutaneously and still achieve levels of C5 inhibition. It was tried in 3 trials called Commodore 1, 2, and 3, both in naive patients and those with treatment on a C5 inhibitor. And it showed that it was certainly as good as eculizumab and ravulizumab. The hope was it could be given at home, given that it's small volume subcutaneously and given every 4 weeks. So it is a more convenient drug. It does block C5. It still has problems with extravascular hemolysis. You still have to vaccinate all these patients against meningococcus, and we're now starting to recommend vaccination against pneumococcus and other encapsulated organisms while patients are on these drugs. Crovalimab adds another choice to our armamentarium. So we now have 6 FDA-approved drugs for treating PNH, and there are several others now undergoing clinical trials. Choosing amongst these treatments is not an easy thing, and it takes a good discussion with a provider who knows the treatment and the choices, and the patient to make a decision about what to do. Some of these drugs block at C5, some are proximal inhibitors. Some are oral, so that makes it more convenient, but you have to make sure the patient is compliant. You have issues with insurance companies and what they'll cover. You have issues with IV access. You have issues with making sure that the patient's not having any other symptoms that need to be investigated. So all of this is a long discussion with the patient. There is no right or wrong answer. They all seem to be very effective, even up front, in terms of treating patients. The only one that I'll say we have to give with a C5 inhibitor is danicopan, so it can't be up front. But otherwise, all the others can be given up front as the initial treatment, or we can give C5 inhibitors since we have more experience with them. And if they have a suboptimal response, we can consider switching them to one of these newer agents.
Yeah. So pozelimab is an anti-C5 antibody. It's being studied in combination with an siRNA that blocks C5 synthesis. And the idea is that the combination would result in good control of C5 expression and activation, in principle being effective against intravascular hemolysis mainly. The issue with C5 inhibition is always going to be the same. And no matter how much we block C5, the possibility of extravascular hemolysis persists because C5 inhibition will replace the effect of CD59, but we are not replacing the loss of CD55, which is there to block C3 accumulation on the surface of red blood cells. The other component that is also relevant with some of these newer C5 inhibitors that I think we should discuss is that there is a polymorphism in C5 that is present in a small proportion of the population, usually people from Asia that are resistant to ravulizumab and eculizumab. these patients can respond to more novel C5 inhibitors, such as ravulizumab.
Tisadolimab is a novel anti-C5 antibody that has mostly been tested in Japan and Asia because they have a problem with a polymorphism in C5 that leaves them unresponsive or poorly responsive to eculizumab and ravulizumab. So this binds a whole new epitope on C5. There is a phase 2 study that was published in a letter to the editor that showed it to be very effective in patients with PNH, even in those who might have the polymorphism. So it's a treatment that'll probably be more used in Asia than in the US, only because we already have C5 inhibitors that work well. And that polymorphism rarely occurs in the US.
Benzobapast is an antibody targeting C5 that is also fused with a protein that inhibits a complement factor H. And the result here is that we both block C5 generation on red cells and also block the accumulation of C3. The result being that this is a parental compound that should be able to control both intravascular and prevent extravascular hemolysis. These studies are still ongoing, but the preliminary results are also quite promising.
There are several other agents that are being investigated. Some of these are oral factor B inhibitors. Really, we have a whole bunch that are coming down the line that are all exciting. I think the biggest issue now is with all these choices is one even better than the other, and how do we know what the biggest adverse events are? I will say that one of the key issues that we've been focusing on is breakthrough hemolysis. So if a patient has a complement activating event, sometimes the levels of complement can get so high that they overwhelm the inhibitor, and you end up with a flare in intravascular hemolysis that can be quite serious. So far, we are looking at all these agents, and maybe some are a little bit better than the others, but I think we're going to need really more time to see if that's true. And I think these newer agents are also focusing on that, saying, can we find a perfect drug that really doesn't have much breakthrough hemolysis? And then we'll have to wait and see. Other adverse events with these drugs, they're all very well tolerated. They all seem to improve thrombotic rates down to very low levels, not completely gone, but to very low levels. And they all have little quirks about them. For example, pegcetacoplan has to be given subcutaneously. You can end up with skin reactions. Some of them have a little bit of mild diarrhea with them. But for the most part, the side effect profiles of all these drugs so far have been pretty incredible in that they've been well tolerated.
Yes, and I think one of the main lessons that we've learned with complement inhibition in PNH is that despite the initial concerns about the risk of infections, actually complement inhibition is overall, I would say, quite a safe approach to treat quite a number of diseases. And PNH has been leading the charge in complement inhibition for many diseases. And it opened the field of complement modifying therapies for other diseases where complement plays a significant pathogenic role, including kidney diseases, ocular diseases, etc. I'm not saying that there is no risk, but certainly the concern related to meningitis or overwhelming infection with proper vaccination does not seem to be a major concern. The main thing is related to education of the patient, that the patient must take the drug, and if they have anything suggestive of a complement amplifying condition, so any vaccine, any recent infection, potential surgery, it's very important that they keep taking the drug. And actually, I've had quite a few patients now on this drug who had such complement amplifying conditions, including surgery, COVID, which is a well-known complement amplifying infection. And as long as they take the drug regularly, the risk of breakthrough hemolysis, in my experience, has been essentially zero, including patients who have had quite extensive surgical procedures while taking the medication. I think now that the disease can be well controlled, in my view at least, the focus should be on improving quality of life. I want these patients to be as normal as possible. And being normal means that the patient can live with minimal to no symptoms related to the disease and can enjoy life like anybody else. And with these novel therapies, I think we can now aim to personalize this therapy. Because one therapeutic approach may be applicable for one patient, and a different approach may be applicable to a different patient. I don't think we want to have a one-size-fits-all approach, but certainly it's very exciting to have so many different treatment options for our patients.
I think David raised great points that quality of life should really be a high focus. These patients are doing well in terms of controlling their blood count levels and controlling complement and feeling much better. But really, we should focus on how well are they living? Are they able to do what they want to do, etc. And he's right. Infections have not really been a problem despite us moving into the proximal inhibitor as targets. So it really has changed things quite dramatically for us. And hopefully we can continue to improve with these therapies and really until we eventually get a cure for this disease. Right now, we are at a very good place where treatments have really made a marked difference in the lives of patients with PNH. The only other thing I'll mention just briefly is the issue of pregnancy in these patients, because right now, none of them have FDA approval for pregnancy, but we have a lot of case series and series that was put together by Richard Kelly showing that eculizumab seems to be fairly safe and improve outcomes. All the other ones, there's a little bit of data, but not enough to feel comfortable yet to use these drugs during pregnancy. So right now, we're using eculizumab as our treatment standard for pregnant females with PNH. The others will have to wait and see.
Thank you, Drs. Castro and Dingli, and many thanks to you, our listeners, for joining us. As a reminder, to view the full program, Clinical Focus in Paroxysmal Nocturnal Hemoglobinuria, New Strategies for Evading the Complement Cascade, please click on the link in the show notes. And be sure to check back regularly for more episodes on other important podcast topics.